Hello, good evening, viewers, and welcome to your favorite show, Ask Dr. Saw. First, let me apologize to you on behalf of myself and Dr. Saw that, as you know, that there were some issues on the platform on which we would be broadcasting on. That's the Guyanese Critic platform. So from last week, when we did the show on leg swelling, I was not able to retrieve those questions because the page is not available, and I was not able to retrieve those questions so that we can answer those questions tonight. I just want to say that I want to apologize to you sincerely for not having those questions tonight. You can still send them, and next week we're gonna deal with them. Tonight we're doing just half an hour, and so that we can be able to catch up back. But the show will be broadcasted on Dr. Saw's page and my page, so you can watch it from there. So again, sorry for the inconveniences of not having those questions to answer, but you can please send them back, and I hope that we can get them for you from next week. Good evening, Dr. Saw.
Good evening, Akash.
How are you doing, sir?
And viewers. Yeah.
All right, cool.
All good with you?
Yeah, very well, Dr. Saw. Well, as you know, Dr. Saw, we had some issues on the platform, and we lost the questions. But for you viewers and patients, I encourage you to send in back your questions. Dr. Saw, tonight we are dealing with chronic coughing, and I myself has had an episode of that for when I know a cough lasts me for a few months. Thankfully, it's gone now, but it's not there anymore. So let me start off by asking you, Dr. Saw. I mean, we know what is a cough. Usually, a cough is something trying, your body reflexes trying to clear something from the throat. I believe that's the basic concept of a cough. But what is chronic cough?
Right. So we know you just said what is a cough. We all cough, so we know what is a cough. But what causes a cough in terms of the mechanism and why you cough, that's one question. And when do we say it's a chronic cough? So you have cough, or medical conditions generally are described as acute. So you have an acute condition. Mm-hmm. You have something called a subacute, and then chronic. So chronic means it's there for a longer period. But in cough, generally, we consider a cough to be chronic if it is greater than 8 weeks.
Right.
So if you've got a cough that you're coughing for more than 8 weeks, we would say that's a chronic cough. Usually a cough up to 3 weeks, we consider that as an acute cough. So, it's a short period of time. Mm-hmm. Between 3 and 8 weeks, we call that a subacute, and greater than 8 weeks, we call that a chronic cough. The question is, we all know what is a cough and why, as you rightly said earlier, why we get a cough. We get a cough because the cough is a reflex mechanism to get rid of something, of course, but it is actually caused by some sort of irritation in the airway. Mm-hmm. So it could either be a mechanical irritation or a chemical irritation. So things like fumes, of course, you can cough. You spray a perfume, sometimes you tend to cough, smoke inhalation, or if there was something physically there, mucus, a foreign body in your throat, food in your throat, those are physical things. So it's some sort of irritant hitting the sensitive respiratory airway, and it triggers a cough reflex. And that is how, you get a cough generally. Why I chose to do a topic on chronic cough and coughing generally, it's a very common thing. All of us cough. I mean, I've been coughing for a while.
I know.
But I think my cough is probably habitual.
Yeah. Or is it?
No, we'll go through all the different causes. Yeah. But cough is so common. We see it all the time. And the most common acute condition would be upper respiratory tract infection, which give rise to a cough. So, however, when it becomes chronic, we tend to be worried. And why it is important, we see in some areas, you have about 15% of the population would have some sort of chronic cough. I don't have data on all regions of the world, but we have some data on isolated areas. You can have a high percentage. We know it accounts for about 10% of specialist referral. So you go to your doctor and you have a cough, it's not going away, you start worrying. And of course, the first thing that comes to mind, and we see all these ads on television that, okay, if you have a chronic cough, see your doctor. And at the back of our mind, we're worried about diseases, serious, sinister pathology. We're worried about cancer. So we can say the impact of chronic cough is huge. We have physical impact, so it impacts our body. When you cough, you get pain. So you can get chest pain when you cough. You can get hoarse throat when you cough. It can affect your sleep. So physically, it affects you. Psychologically, it can affect you. You're worried about, oh, right, could this be cancer? Could this be TB? Do I have something else going on? Am I going to die? Is this the beginning of something more serious? So psychologically, it has a great impact. Socially, I mean, it's a massive impact socially. You know,
that's right.
During the COVID time.
Yeah, you dare not cough among people.
Absolutely. You would see, I would go in the train, for instance, and you see somebody coughing and everybody would walk away.
Right.
And give that person space.
Yeah.
So think about it, you're coughing at your job. Your co-worker is going to say, right, you're ill, they don't want to be around you. They may think you have a contagious condition. So it has physical, psychological, social impact. So it's not just a trivial topic. And as we go on, I'll explain all the details of, but the impact is huge.
Doc, I just want to ask this question. Look, when people have a cold, I know that usually it's accompanied by a cough, and then you'll have that cough, then you'll bring up mucus, you say you're coughing up cold and so on, and then that cough morphs into a dry cough. And that dry cough is irritant, nighttime you're sleeping and you can't sleep properly, it's, your whole body. What causes that? What causes that?
Well, I explain that to patients in a way where I say, okay, you have so that is an acute cough going on a little bit longer than just that 3 weeks, and it go on for a little bit longer. But it is not to say that there was something more serious. So you've described a situation there where you have, first you start with an upper respiratory tract infection, and the most common cause for that would be a viral infection. So there are lots of viruses. Your common cold, influenza, common cold, whatever upper respiratory tract infection you've got, it can manifest with a cough and cold. So you have mucus. I said just now that you have some irritants to the airway. So when the virus gets into your airway, you have some glands. So our airway, from our nose going down to our sinuses, our throat, you have what we call the trachea, and then it branches into the bronchus, and it leads into the lung. And after the bronchus, you have something called bronchiole. So these are smaller airways, right? Now, in the bronchus, you have cells that produce mucus. So when there's an infection into those cells, you have an increase in mucus production. And also, the body has a way, you have some cells that line the airway where it pushes matter, like physical irritant, it pushes it out so that we can bring it up.
Right.
And we expectorate or, spit it out or whatever it is. So there are some cells, we call it cilia cells, that move, it brushes it cleans the airway.
Right.
So when you have an infection, all those bits are inhibited, you have more mucus production, and it have a dysregulation of that system. Now, an acute cough, as you say, it goes away. You heal from that acute cough, meaning that the fever and the acute episode resolve, and you're left with a little dry chronic cough.
Yes.
Now, I explain that as a little, what we call a post-inflammatory cough or post-viral cough, generally. And this is a very common condition. As a matter of fact, I will say majority of patients that I've seen coming to me for cough symptoms would be because of this condition called post-inflammatory or post-viral cough. And that is classic. The history is clear. They've come with a viral infection, cough, cold, runny nose for 2-3 weeks, and then they're left with a cough for another couple of weeks. So that's a post-inflammatory cough. And how I explain it is that the airway is not fully healed, so the airway is still inflamed, and you're setting off a vicious cycle. So every time you cough, you're creating irritation to the airway, and you're having that vicious cycle. So it takes longer to heal. And sometimes what I do, I would say, okay, we need to break that cycle. I would give some steroid, and that is via inhalation as an anti-inflammatory, and I would give a cough suppressant, and just to break that cycle. And most times that will go away. You know, it may last for 6 weeks, 4, 6 weeks, 8 weeks, whatever. So a majority of those coughs will go away, but the classic history is that it starts with viral infection, and you know you have cough, cold, runny nose, and you go on. So you can be reassured there that, oh, well, this is nothing worrying, and after a couple of months, it goes, 8 weeks probably. But if the cough goes on for more than 8 weeks now, we say this is a chronic cough, and let's start looking for other causes. Mm-hmm. Now, in looking at cough, I tend to describe it in a very, simple way for people to understand. You're coughing, you always think, which organ you're worried about? Always your lungs.
Your lungs, yes.
All right. So if you're coughing for a long period, you always worry, is there something in my lung? Correct, right? Your lungs.
Yes.
You have, and of course, we have worrying features, non-worrying things. So if you have, the common things would be infection. So the first thing I would look for, ensure that there isn't any infection. If you have acute infection, you would have cough and cold runny nose with that. Chronic infection, so cough that go on more than 2 months now, we are looking at chronic infection. And what are the chronic infections? You have conditions like tuberculosis, and that is endemic as well. In Guyana, we have, tuberculosis is common there. We don't see it a lot in the Western world, but of course it's still, because of the migration and traveling, we still have TB as in communities here in the UK. So yes, so tuberculosis. Now, the things we look for TB, we look for associated symptoms. So this is not just your cough that is chronic alone. We'd expect patients to be feverish. So it's an infection. So you may have a little bit of fever. You may also have night sweats and weight loss, and you may bring up blood. So if you have features of fever, night sweat, weight loss, and bringing up blood, we call that hemoptysis. We want to make sure this is not TB or this is not cancer. Mm-hmm. So those are the important chronic cough red flags. So the red flags, the things that you look out for, that, okay, I'm worried about this cough now. You've seen a patient coughing for 2 months, they've lost some weight, they've got fever, they've got night sweats, they've got weight loss. You would always want to make sure this is not TB or this is not a cancer. And of course, there are other conditions like bronchitis. Patients who smoke, they can have bronchitis. Bronchitis eventually, that can lead to something called COPD, chronic obstructive pulmonary disease, COPD. You've heard of that, yes. I'm sure. So, yeah. And it's similar to asthma presentation, but whereas asthma is caused by a condition that has got an immunologic basis, COPD is more caused by a condition which there is a predominant physical or irritation of the airway, sometimes done by an irritant of the airway. So those are lungs. So I'm describing lung conditions of chronic cough.
Yes, yes.
Right, so we talk infection, we talk about cancer. So you're looking for infection, you're looking for cancer. And of course, those allergic conditions now. So now we're looking at sensitive airway, asthma. So COPD is similar to asthma, where you have obstruction. So they're called obstructive lung disease. So the idea is you breathe in in generally, and your body has a natural recoil. So most times when we breathe in, the lung, we don't deliberately breathe out.
That's right.
It's
Yeah.
like elastic. The lung is like elastic. It recoils and pushes the air out. When you have asthma, the airway is blocked. So you breathe in well, but the airway is blocked. So when you breathe out, there's an obstruction. Likewise, with COPD, they tend to present similarly with obstruction. You can breathe in better, but you breathe out, there's an effort to breathe out.
Mm-hmm.
So those are your lung conditions. And of course, you have, there are conditions you can born with, something called cystic fibrosis, where, there's obstruction of the airway because of the cells in the airway malfunctioning, and you produce all these mucus that are sticky and get clogged up. You've got conditions of the airway, also something called bronchiectasis, where the airway gets dilated and get infected. Infections get into it and give you chronic cough. So these are the lung causes, and it is very, very important. We all want to make sure there's nothing wrong with our lungs. And so once you have a chronic cough and you have those danger signs, you'll want to assess the patient, and I'll talk about that shortly.
Yeah.
But let us look at other causes of coughing. So not only the lungs.
Right.
So a lot of people are surprised.
But I want to ask you also, Doc, to expand a little bit on smoker's cough, because that is something I hear a lot about.
Yes. Okay. Smoker's cough is actually a smoker that is coughing. But how would they describe that? The cough is as a result of irritant to the airway, that is smoke inhalation.
Yes.
And it damages the airway.
Okay.
So the airway, as I said, has got these cells that produce mucus. And when you have constant irritation, it causes hypertrophy or enlargement of these mucus-producing cells. And it causes increased mucus production. So a smoker's cough will be like a cough that produces a lot of mucus. And lots of time that leads on to bronchitis and then COPD. So as the smoke gets into the airway, it causes inflammation. And the bronchitis is defined, generally we can describe bronchitis as coughing, productive cough, that is cough with sputum, so that's like a wet cough.
Right.
And that goes on for 3 months in a year.
Wow.
For 3 years.
Wow.
If somebody presents like that, we'll say this is classic bronchitis. Now, as the airway gets more and more inflamed, I said the smaller airway doesn't produce so much mucus. But with the smoke, in a normal lung, the smaller airway doesn't produce so much mucus. That's called the bronchioles. And at the end of that, you get that little balloon-like thing, that is the alveoli, where you have the gas exchange. That's
right.
where the air gets in. So like a grape, a bunch of grapes,
yeah.
where those little grapes are the alveoli, right? Now that's you have the exchange of gas, the blood and the gas, the oxygen exchange there. So in in this COPD condition, those alveoli, they expand and the air gets stuck. So think about the whole airway is affected. The bigger airways producing more mucus, the smaller airways get dilated, and they also produce more mucus, and the air gets trapped. And that is called COPD. So the smoker's cough ranges from bronchitis to it leads on to COPD, where you get obstruction of the air. So you cough a lot, and then you have difficulty. You start to wheeze, and you go like, you know, wheezing. So wheezing is that you're taking an effort, and you have that whistling sound as you breathe out.
Gonna say a pan for breath.
Yeah, yes.
You know that?
So it's a very. I mean, if we were to, normally I would tell patients when they're smoking, right? I'd say, okay, lots of people talking about lung cancer And of course, smoking with lung cancer, it's a big deal. And yes, it's one of the biggest risk factors for lung cancer. But besides that, so lots of people would say, okay, that lung cancer, I'll check for that regularly.
Mm-hmm.
But I usually say to them, that is a part of the problem. But COPD actually, we have never shown a patient, I mean, we wouldn't go on, if someone were to see a family or you see patient with COPD, it's a real distressing disease. Some people walk around with oxygen tank.
Yes.
Because they don't have enough oxygen. They have to have oxygen at home. And that's what COPD, and smoking is the number one cause for it. And of course, you can have not only active smoking, but you can have passive smoking. You can also have certain exposure in work industries where you have pollutant, inhaled pollutant that irritates the airway. That is what you'll get with your smoker's cough. But moving on from the lung now, so we have covered majority of the lung.
Yes. And you did say there are other things that may cause a cough.
Absolutely. So the heart. I always tell patients, whenever you have conditions that you think is a lung, always think also about the heart. So when you get shortness of breath, some people say, right, for me to know it's my heart, you have to have chest pain. No, you can have shortness of breath. I've had many patients come to me with just shortness of breath, and I say, this is due to your heart. And when we check their heart, they've got a blockage. Right? But in coughing, generally, you can have coughing as a result of fluid in the lung. The same mucus you get from infection or whatever it causes, you can also have fluid because the heart meant to pump blood out. If the heart is weak, it cannot pump all the blood that is received. You have pooling of blood. We talk about leg swelling, and I also last week.
Yes.
And I also said that fluid can get into the lungs. So when you have fluid in the lungs, you can have chronic cough. But most of these patients, the heart failure, so we define that as heart failure, and they would sleep on you ask a patient, how much pillow do you sleep on at night? They will sleep on 2-3 pillows a night because they have to sit up.
Elevated.
And they have difficulty lying flat. Of course, they may have leg swelling as well, and also they may cough up frothy, pinkish sputum. So if you see a patient or anyone can't sleep, lie flat in bed, they coughing up more at night, they get pinkish sputum, and they get leg swelling, you can say almost always this is due to heart failure. So heart condition, of course, can give rise to that. And of course, with heart failure can be as a result of damage to the muscle. It can be as a result of damage to the valves. So patients with valve disease. So heart condition is a big deal. Another common cause of chronic cough is acid reflux. So we call GOR, the gastroesophageal reflux disease.
Yes.
So acid reflux, very, very common. So I normally tell patients, if we can't find, we'll check their lungs, nothing to do with the lungs. I would look for acid reflux. Heartburns, they may or may not. So sometimes you may have heartburn, classic heartburn that you get from acid reflux, but sometimes you just get a cough. And your throat, you may have a little sore throat or an irritation of the throat because acid comes up and gives you that throat irritation, and you cough. Yes, indigestion symptoms. So always look for that. We would tend to I will check patients for something called H. pylori, a bug that lives in the stomach. And sometimes I just give a blind trial of anti-acid medication. So we cover heart, we cover gastrointestinal. The other condition would be ENT conditions, ear, nose, and throat.
Yeah.
And big on that is sinus problem. So patients come in with coughing, chronic cough. Again, I would say, do you have blocked nose? Do you have nasal congestion? Do you feel as if your sinus, your face is heavy? When you bend your head down, it is heavy. So that is congestion in the sinuses. Now, your sinus drains at the back of the throat. You know, when patients will come to you and say they have head cold, that's
right,
a type of sinusitis.
Yes.
So you have sinuses here, the frontal sinuses. You have sinuses in your face, and those sinuses they drain and they produce mucus, and of course that will give rise to we call the postnasal drip. So the sinus drains, you have dripping at the back of the throat. That's an irritant, and it triggers a cough mechanism. So ENT problem, that is big. Yeah, those are your systemic, conditions of the body that give rise to coughing. Of course, there are other some medication can cause coughing. So medication like a drug called ACE inhibitors, blood pressure tablet. There's a blood pressure, a type of tablet called ACE inhibitors, like ramipril, lisinopril, enalapril, captopril. Those are the drugs. They cause a conversion into the lung, and they can give rise to coughing. So if somebody say to me that they have just started on a medication and they started to cough, then of course I would say, maybe the medication is a cause.
What I wanted to ask you, Doc, was I wanted to ask you about the how do you investigate chronic cough? But the amount you've done so well with your explanation on the various aspects is that I don't need to ask you that. But what I want to say is that I remember in the 70s, and this just stuck with me in my head. Maybe in the late 70s, early 80s, I saw a movie. I don't know if you probably would have seen a movie called Kalakar. With right, it's a good movie with Sridevi. I think she made her debut. But here's what happened in the movie: the guy at the end of it, he was coughing, and he would, when you look at his cloth, you saw blood on it, right? And that thing stuck with me forever. That they said in the movie that this guy had this he had this cancer and he was dying, and he was a singer. And anyway, that panned out like that. But ever since then, that thing stuck in my head that if you're coughing and you see blood, you're gonna die. But what are some of the you did mention coughing up certain things, but what are some of the other major red flags that when you see something, get to your physician right away?
No, absolutely. So blood is a big one, and coughing with blood. So we talk about chronic cough and when do you weight loss. Weight loss is a big one. Normally, you have a viral infection. I don't expect you to lose weight. If patients start having weight loss with chronic cough, of course, we want to make sure it's not cancer. Night sweats, sweating, and fever.
The 70s, I saw an Indian movie called Kalakar, and the star by for the movie, Kunal Goswami. I remember the end of the movie, he was coughing, and every time, and then when he started coughing, he would see blood on this white cloth that he was coughing in, and that thing stuck in my head because obviously he died at the end of the movie, and it stuck in me that if you're gonna cough and you see blood in your cough, you're gonna die. You better see a doctor right away. Doc, I mean, what are some of the other red flags that we need to look at when you have a cough?
Blood is dramatic, of course. And
Of
course, blood is dramatic, and you think, hey, this is not just an ordinary cough, it's serious.
Right.
But classically, of course, anytime you see coughing that is chronic, that is over 8 weeks with blood, we want to make sure it's not TB first, and we want to rule out two important conditions: TB and lung cancer.
That's right. Yeah.
Those are the two common things we want to rule out. However, you would have other red flags. Besides blood, you may have fever, night sweats, and weight loss. So fever, night sweat, weight loss, blood, shortness of breath. Those are your classic red flags that if you have those conditions, those symptoms and signs with chronic cough, you would want to investigate that patient for those sinister pathology that, of course, can be fatal if it is not actioned early. So yeah, that is your red flag in a nutshell, really.
Brilliant. So what I want to close off with tonight is talk to us a little bit about management. How do you manage chronic cough?
Absolutely. So before I touch on that, I know we have limited time, but I just want to touch on investigation because that can help us in terms of the management. So when we talk about investigation, if you're thinking something acute, the body has got an infection, and there's inflammation in the body, you can do a blood test to check the inflammatory markers. So your white blood cell will be high, and some inflammatory markers called ESR, CRP. So these are patients who have got some form of infection. Of course, chest x-ray, we will do a chest x-ray as well. and a chest x-ray. Now, I just want people to understand this. I've seen many, many cases where your chest x-ray is normal, but you still have cancer. So a chest x-ray is good to pick up infection like tuberculosis and other pneumonia and things like that. Chest x-ray would not tell you if you have, necessarily tell you if you have asthma. Chest x-ray would not necessarily tell you if you have, it can tell you sometimes in COPD, it can tell you that you have trapping of air. So there are some features of the x-ray can tell you that. But it is not that if your chest x-ray is normal, you do not have a serious condition. You can still have a serious condition. Sputum test, you want to test your saliva. So if you think this is an infection like tuberculosis, we send the sputum, you spit in a container, we send it to the lab looking for the bacteria. So you have the chest x-ray. Now, if someone, you investigate them, chest x-ray is normal, sputum test is negative, the bloods didn't show anything significant, you will go on, I will go on to do a CT scan of that patient. So a CT scan is more sensitive and it picks up smaller lesion. And there are two conditions, importantly, that you have to look for. Of course, cancer, the big one. And also you can have something called lung fibrosis. So we didn't talk much about that, but that's another lung condition that can cause coughing and shortness of breath, where, as I said, the lung has got that elasticity and it expands and closes, but in fibrosis, it stiffens, it's stiff lung. So the lung doesn't expand and recoil so nicely. And usually it's chronic inflammation, and there are lots of theories as to the causes. Infection, inflammation, they can call that certain drugs. They can call lung fibrosis. They can cause lung fibrosis. And of course, a CT scan will do that. There's an important test for asthma and COPD. We do something called spirometry. And spirometry is where you breathe into, you breathe in and you blow out and they measure the exhalation and inhalation and how you breathe in and out. And that can tell you that if you're obstructed, if there's an obstruction to the flow of air outward. And the other one is something called bronchoscopy. If we can't find a cause and we're still looking and we want to know if there's cancer cell, we put a camera into your lungs and we do some washings and scrapings and take some sample from the lungs. Okay. And then we put it under the microscope and we see if there's cancer cell or if there are signs of infection. So that's for your investigation.
So I want to talk to you a little bit about management. And let me tell you what happened when I have a cough that is going on for a long time, especially a dry cough that you can't sleep at nights. Here's what I used to do. And I would go to the pharmacy and buy Piriton, right, which is an antihistamine. And I would take one of that Piriton at night, and it helped. Now, I want you to tell me if maybe I'm wrong to do that. I'm diagnosing, but why is it that helped? And what is the right way of managing chronic coughing?
So yes, to an extent that will help, depending on your cause of your cough. So in management, we have to look at, we have just gone through a list of many causes.
Right.
And of course, depending on your the cause, that's how you manage it, right? But let us look at some generic things. Some general thing, you're coughing. You said Piriton is a very common drug that is commonly used, antihistamine generally. Yeah. They have some properties where they can drive the secretion. And also, I even tell parents generally when they come and they say, right, my child is coughing and not sleeping and disturbing me at night, and they're having this annoying cough at night, I advise them to use Piriton at night. And it serves two purposes. Yes. Besides work as drying up some of the secretion.
Makes you sleep.
It makes you sleep.
Yeah.
Now, I said to you earlier that sometimes you're into that vicious cycle where you're coughing, you're causing inflammation. Every time you cough, you're causing vibration and trauma to the airway, and you're creating that vicious cycle. So these are the people who we know the cough is not due to something more sinister. This is your post-viral cough that we talked about.
Yes.
So, of course, what you want to do there now, you want to give supportive treatment or you want to give symptomatic treatment. Mm-hmm. So in medicine generally, when we treat in a condition, they are what we call symptomatic management and we have specific management to that condition. So you have influenza. Let's say you have flu. There's no treatment I can give you for flu. Of course, there's some antiviral like Tamiflu and those antiviral tablet, but majority of patients we don't give anything. However, we will treat those patients symptomatically. We want to control their fever. So you give them paracetamol, ibuprofen for the temperature, aches and pains in their body. You give them a pain relief, runny nose, we give them a decongestant. Then, so it is all about that symptomatic management. And what you described there was you were treating your symptoms, and you were hoping that whatever this cause of this cough, it will just go away.
Right.
But you did not treat that did not actually treat the cause of the cough. The cause of the cough generally what you've had there more than likely would have been a post-viral. After the virus, your airway got inflamed and you continue to cough. Now, this is an important, there are a couple of management I just want to discuss briefly.
Sure.
So I said lung conditions, just in summary then, we have lung conditions, and the common lung conditions would be infection, and we know specific infection would be antibiotics, right? So if you have proper pneumonia, you have TB, you have fungal infection of the lung, whatever it is, you give the treatment for that infection. So that's a specific type of antibiotics you will give for that infection. If you have cancer of the lung, of course, that is a different ball game. You have, of course, sometimes they remove part of the lung and then they follow up with radiotherapy, chemotherapy, whatever that cancer treatment is, right? And then, of course, you have the big chunk of lung condition, which would be sensitive and allergic condition, and airway obstruction, and that would be your asthma and your COPD. Now, the hallmark of asthma and COPD would be drugs that do a couple of things. One, you want a drug that dry up your secretion. So in COPD, asthma, we give that as well, but more so in COPD. So you want to give, there are drugs we call anticholinergic, Atrovent, commonly used one in asthma, in COPD, Atrovent and in asthma. It dries the secretion, and then you want to give another drug that opens the airway. So the airway in those conditions, the airway narrows up. So they go into spasm. So you want to give a drug that relaxes the airway and open it, and that would be your salbutamol inhaler. So that's a blue inhaler.
Right.
And then you have the brown inhaler is a steroid inhaler, and that is given as an anti-inflammatory. So in those two conditions, asthma and COPD, you could say the hallmark of treatment would be three types of drugs. One is a drug to relax the airway, that's your blue inhaler.
You're right.
Secondly is a drug to dry up the secretion, and that's your other inhaler, Atrovent. And the third would be an anti-inflammatory, which will take away inflammation, that's your steroid. So those three drugs generally will cover your COPD, asthma in different, hierarchy in how we use them. Coming to your reflux cough, so the cough is a result of acid reflux.
Right.
You'll give anti-reflux medication, and that would be omeprazole, lansoprazole, Nexium, Gaviscon, Pepto-Bismol, and of course you want to try the underlying cause. Find the underlying cause and treat that as well. Heart failure, of course, I separate. You'll give water tablet to dry out the lung, the fluid in the lung. So it's diuretic usage. That is in summary. Just to touch on two more medication. So we talk a lot about cough medicine, and it's a big multi-million-dollar industry.
Right.
Do we think cough medicine, do they actually work?
Some of them are very expensive, I can tell you that.
I mean, the evidence is very, very weak on the use of cough medicine.
Yeah.
The evidence is very weak on the benefits of it generally. It's more of a supportive type of, treatment, and yes, if it's going to help you, it probably the impact is negligible. But of course, we use it. We want to give something. We want to use something. It's hard breaking to see your child coughing and not
That's
doing
right.
anything.
That's right. And no, yeah. You try anything, man.
So there are two types of medication, generally cough medicine, they're made of, or we describe them. We have what we call an expectorant.
Expectorant, yeah.
And then you have cough suppressants.
Mm-hmm.
So the expectorant, the intention of the expectorant is, as I said, the irritation, the coughing is caused by irritation of the airway. So the intention of the expectorant is for you to expel.
Yeah, that's right, yeah.
Whatever is irritating your airway. So they break up the mucus and you cough it up. So that's one type of cough medicine, and the other type is a cough suppressant. So there's a cough, it's a reflex mechanism, and it suppresses that cough reflex. And the type of drug that usually you get in it, they are kind of opiates type of drug, like codeine-based drug. So this suppresses your neurological system in a way, and it suppresses the cough reflex. So that's the kind of medication that you use, but the evidence for cough medicine, they're not really very strong. Most times we give it as an adjunct to whatever else you're treating, and you're hoping with time your condition would resolve. In post-viral cough, the type of coughing that you described where you have a cold initially and you're left with a cough, I sometimes, if it goes on for more than 6 to 8 weeks, I will add a steroid inhaler. Okay. Now, we choose inhaler versus steroid tablets because tablets have got more systemic effect. So, prednisolone, that's a tablet, steroid tablet, we don't want to give that because it tends to act more in a way where it got more side effects. So, we try to give it inhalation, you pull it into the lung, where it acts locally and you don't have so much of systemic effect. But that's your summary of management.
Thank you so much, Doc. Again, viewers and patients, thank you so much for joining us tonight. I explained earlier we could not have answered your questions from last week because we lost the link because of the platform going down. But again, thank you so much for sending your questions tonight, and we are sure going to be answering them next week. As I said, the show will be running for now on Dr. SAWH and my page and myself. So you can join us, and thank you so much for all the persons that have been sharing it already. Thank you so much. Again, on behalf of the team here, we want to say thank you for joining us and staying with us also. And remember, as I always say, too many accidents. Let's slow down. Let's watch out for those who are not watching out for us. And from me here, I would like to say, stay healthy, Dr. SAWH.
Yes, likewise. Thank you and your team, and to the viewers, thanks for watching. And of course, we're happy to share the knowledge and to share the page as well as much as we can. Thanks a lot, and good night, everyone.
All right, good evening. Bye.